Hi everyone, my name is Sheena Mohanichandran Vasandakumari and I am a transitional nurse practitioner currently working within a residential aged care facility on the Gold Coast, Queensland. In my role, I have the privilege of working alongside some of the most vulnerable members of our community, older adults living with chronic illnesses, frailty and complex care needs. Each day, my focus is on optimizing symptom control, supporting end-of-life decision-making, and collaborating with multidisciplinary teams, including general practitioners, pharmacists, nurses, and allied health professionals, to ensure that residents receive the highest standard of compassionate, evidence-based care. However, despite the dedication of aged care teams, there remain systemic gaps in the way palliative care is delivered across residential settings. Too often, we see delays in recognizing clinical deteriorations, which lead to avoidable hospital transfers that are distressing for residents and their families. We encounter limited access to timely palliative reviews, meaning that symptom escalation, pain, dyspnea, agitation is sometimes managed reactively rather than proactively. After there remains inconsistent confidence among staff in managing complex end-of-life symptoms, resulting in variability in comfort measures and missed opportunities for meaningful advanced care planning. These gaps are not due to a lack of compassion or commitment. They reflect systemic barriers, workforce constraints, and the absence of a sustainable on-site clinical leadership model that can respond swiftly to residents' changing needs. In many facilities, palliative care remains heavily reliant on external general practitioners who are often stretched across multiple sites. As a result, critical decisions are sometimes delayed, and the holistic person-centered approach that palliative care demands can become fragmented.
Every day I meet residents whose stories end quietly behind aged care walls, sometimes with dignity and comfort, and sometimes without it. As a nurse working in aged care and palliative settings, I've witnessed moments of compassion, but also moments when symptoms go unrecognised and families feel unsupported. This is where the nurse practitioner's role can make a profound difference. In Australia, almost 1/3 of people die in residential aged care. Studies highlight that many experience avoidable hospital transfers in their final days, despite preferring to die in place. Pain, dyspnea, and agitation are among the most distressing symptoms. Yet, due to fragmented communication and resource limitations, these are not always managed promptly. Families often report feeling unprepared for the dying process. This is not a failure of care. It's a failure of systems. The evidence is clear. Integrating nurse practitioners in palliative care improves outcomes. Research from Australia demonstrates that NP-led models reduce hospitalizations, improve family satisfaction, and ensure timely access to symptom control. Nurse practitioners can independently assess, prescribe, and coordinate complex care, bridging medical and nursing perspectives in real time. Yet many aged care facilities still rely solely on GP-based or visiting palliative services, often stretched thin. As a future nurse practitioner, I envision an integrated NP-led palliative care model embedded within residential aged care. This model will combine proactive symptom assessment, anticipatory prescribing, and staff education to enhance end-of-life care quality. I see the NP as a consistent clinical anchor, available to residents, families, and staff, ensuring decisions are timely, compassionate, and evidence-based. My leadership goal is to build capacity, confidence, and continuity, transforming aged care into a place where dying well is an expectation, not an exception. To move from vision to reality, my proposed research will explore the question: how does NP-led palliative care within residential aged care influence symptom control, hospital transfer rates, and family satisfaction compared to standard GP-led care? Using the PICO framework: population, older adults receiving end-of-life care in residential aged care facilities; intervention, NP-led palliative model with proactive symptom management and staff education; comparison, usual GP-led or when required palliative input; outcomes, improved symptom control, reduced hospital transfers, and enhanced family satisfaction. The study will use a mixed methods design, combining quantitative outcome data with qualitative interviews from staff and families. Change in aged care requires more than new policies. It demands clinical leadership that translates evidence into practice. As a nurse practitioner, I will act as a change agent, embedding research-based interventions into everyday care, mentoring staff to build capability, and advocating for equitable access to palliative and end-of-life support for all residents. My practice aligns with the Nurse Practitioner Standards for Practice, NMBA 2021, particularly within the domains of clinical leadership, education, and research. Through collaboration with general practitioners, pharmacists, and allied health professionals, I aim to strengthen multidisciplinary coordination and empower nursing teams to deliver compassionate, person-centered care. By modeling reflective, evidence-informed practice, I will contribute to a sustainable aged care framework that upholds dignity, comfort, and informed choice, ensuring that every resident's final journey is supported by clinical excellence and human connection. The future of aged care is not merely about adding years to life. It is about adding life, meaning, and dignity to every year lived. As Australia's population continues to age, the need for compassionate, skilled, and evidence-based palliative care within residential aged care facilities has never been more urgent. My vision is that every aged care facility across Australia will have nurse practitioners embedded as core members of palliative care teams, leading by example, integrating research into daily practice, and ensuring that no resident faces the end of life without comfort, dignity, and choice. In this model, nurse practitioners act as transformational leaders and change agents. They bring advanced clinical expertise to the bedside, bridging gaps between medical, nursing, and allied healthcare. They empower staff through mentorship, foster confidence in symptom management, and create a culture where end-of-life care is not an afterthought, but a priority grounded in compassion and evidence. Nurse practitioners also drive system-level reform by collecting and analysing outcomes, leading quality improvement projects, and advocating for policy that recognises palliative care as a human right. Their presence enhances continuity, reduces unnecessary hospital transfers, and ensures that care decisions align with residents' values and families' wishes. My research journey is one step toward building the evidence base that will sustain this vision. Through exploring NP-enhanced palliative models, I aim to demonstrate measurable improvements in symptom control, satisfaction, and system efficiency. More importantly, it is about redefining what good care means, care that honors the human experience of dying and supports those who provide it. The ultimate goal is a future where every residential aged care facilities in Australia has an embedded nurse practitioner, leading interdisciplinary teams, mentoring staff, and championing the values of dignity, comfort, and respect at the end of life. Because the true measure of our health system is not just how long people live, but how well they are cared for when living becomes fragile. This research is not just about data, it's about stories. The stories of residents who die peacefully in the place they call home, of nurses who rediscover confidence in their clinical judgment, of families who find comfort in knowing their loved one was cared for with dignity. The outcomes of this research could inform national policy, guide workforce planning, and help define what best practice palliative care in aged care truly looks like. Because what we do in these final chapters of life reflects who we are as a society, our values, our compassion, and our respect for human dignity. So, as I close this presentation, I return to that simple but defining vision to add life to years. Through evidence, through education, and through empowered clinical leadership, nurse practitioners can lead this transformation, ensuring that aged care in Australia is not a place of decline, but a place of comfort, connection, and meaning. My research is one step toward that future. A future where we do not measure success by how long someone lives, but by how gently, how meaningfully, and how humanely we help them live and die. In closing, this research represents more than an academic pursuit. It is a call to action. A call to reimagine aged care as a place where advanced nursing practice leads the way in delivering timely, person-centered, and compassionate care. It is a call to strengthen the clinical voice of nurses, to translate evidence into practice, and to ensure that no resident faces the end of life without comfort, dignity, and respect. As a transitional nurse practitioner, I stand committed to advancing this vision, to building bridges between research and practice, between leadership and compassion, and between policy and the lived experience of aging. By embedding nurse practitioners in aged care, we are not just filling a service gap. We are redefining what quality of life and quality of death can mean within our communities. Because every life deserves to be lived well, and every ending deserves to be met with grace. Thank you.